Good evening. This is Joe Gallo of ANCAN, and I'd like to welcome you to another in our series of webinars. And you'll get a little bit more information on that in a couple of moments with our guest speaker, Dr. Morgan. But first, before we get started, a couple of administrative points, if you would. First off, the standard disclaimer: anything that you hear, see, or is presented tonight is not to be perceived as being any medical advice. It's information only. It's good information that you can use then to take to your own doctor or your own medical team. And our sponsors, I'd like to thank our sponsors. These folks are the ones that help us make all this possible. And that includes Bayer, Pfizer, MyEvent, Foundation Medicine, Myriad Genetics, Janssen, Telix, and Blue Earth. So again, thanks to all those folks. And now with that, I'd just like to introduce I call him fearless leader, but the head of ANCAN, Rick Davis.
Good evening, everybody, and it's a pleasure to be back introducing. I haven't done it for a while. We've had some other folks who have taken the responsibility over from me, but this is a webinar that I'm interested to hear because I noticed through attending some of the AS and low and intermediate groups that quite often people were very confused as to which tests they should be taking, and was there a difference in the test, and how do they work, and what do they do. And as you're soon going to hear, there's really only one man in the country who knows the answer to that, because we've been asking several people, and the guru in this space, Howard Walensky, told me, no, it's Todd Morgan's your man. So we have him here tonight. We also have one of our sponsors, only or simply because they're the only sponsor that makes a test that we're going to talk about. So we asked them to come in, and this is totally non-branded. We don't endorse one test over another, but we do like Myriad and we do like their people, and they work with Dr. Morgan, so there's good reason for Myriad to be here tonight. So if you don't know ANCAN, we run around 30 events a month now. About half our programming is for prostate cancer. The rest of it is for all kinds of other things, and everything from interviews to art classes. So we really encourage you to sign up, go to our website, take a look, sign up, and join some of our programming, and especially tell your friends. Thanks for attending, and with that, I'm going to hand it over to Sunny Yerish from Myriad.
Hi, good evening, everyone. I'm Sunny Yerish. I'm Director of Marketing at Myriad Genetics. First of all, a big thank you to ANCAN, to Joe, to Rick for setting up this webinar. We need more places like this where we can learn about the role of genetic testing in prostate cancer. At Myriad, we offer a test called Polaris, but tonight I'm not here to talk about our test. Instead, I'm here to show how much we value the work that groups like ANCAN do. We believe in empowering patients and their families with the knowledge they need to make the most informed decisions about their health. Dr. Todd Morgan is going to talk about various tests tonight, which include Polaris. We're looking forward to hearing his insightful perspective. These open conversations are what we need to expand patients and their families' understanding of this test. What's most important is that we are raising awareness about genetic testing and genomic tests. They can be game changers in how we treat prostate cancer. Thanks. I can't wait to learn from this session.
Okay. So Dr. Todd Morgan is Chief of Urologic Oncology at Michigan Medicine. And I have to put in a plug for Michigan football. Go Blue. Dr. Morgan is a top gun in favor of active surveillance and the use of genomics in prostate cancer care. He has participated in writing the American Urological Association's Advanced Prostate Cancer Guidelines, the NCCN Prostate Cancer Early Detection Guidelines, the ASCO Localized Prostate Cancer Guidelines, and the ASCO Molecular Markers for Prostate Cancer Guidelines. A lot of guidelines. Now, I want to take note of something that Dr. Morgan did in 2021. The NCCN, National Comprehensive Cancer Network, tried in 2021 to downgrade the status of active surveillance and to put it on the same level as surgery and radiation. Dr. Morgan was perhaps the lone dissenter to that change. He was the last angry man, and he stood his ground in opposition. Thanks to his advocacy and that by other urologists and patient support groups, including ANCAN, NCCN reversed its position. Dr. Morgan is a leading researcher on the use of DNA in prostate cancer. He's the principal investigator of a new study conducting an unprecedented comparison of the 3 leading genomics tests. This is part of the Music Urological Surgery Improvement Collaborative, MUSIC, which has the largest uptake of active surveillance in the country. And I think he's calling this one G major, because in music, they love to use puns. But I welcome Dr. Morgan, and I'm going to disappear now.
Well, yeah, so let me just say first again, thank you to Howard for that kind intro. And I really just want to take a second to acknowledge ANCAN and the work that you guys do. I mean, there's so much that we know when we see patients with prostate cancer, and we see lots and lots of patients, and we know a lot about medicine and biology and surgery and radiation, and yet still there's so much that we don't know if we're a doctor who's never had prostate cancer in particular. And so groups like this provide just so much information and support for patients. And I have so many patients who have benefited from this groups and other groups like it support. So thank you for that. So let me just kind of step way back and say, you know, what are we even talking about? So genomic and genetic tests, it's incredibly confusing. I was asked to talk about the black box. And I think for patients, the black box is just faith, right? It's, you know, we walk into the office and a patient has prostate cancer, and there's so much trust that you have to have in the system. Hold on one second, I'm getting a camera error. Another error, look, one sec. All right, I'm gonna try this without the video for a sec. Got error on my screen. So back to the black, so I got the black box, and you've all heard about tests like Polaris and Decipher and Oncotype DX, and we've heard about genetic tests, homologous recombination repair is what HRR stands for. Maybe you've heard about something called StarCap and other nomograms. And what I want to talk about, you know, here is this incredibly important table from the NCCN guidelines. And I think if you look at the guidelines, you know, you'll see that there's 4 different kinds of clinical nomograms, and there's something called Artera AI genetic, or Artera AI artificial intelligence testing, and there's the gene expression testing like Decipher, Polaris, and Oncotype. and then finally, germline testing. I'm sorry, my computer keeps switching in and out. Give me 1 sec. I'm gonna try to fix this. Let's see. Can you tell me, are we back online?
Yes, you're good to go.
So, if we look along the localized prostate cancer continuum, right, there's early detection, there's diagnosis and staging, there's initial treatment, and then there's something called survivorship. In early detection, there's a bunch of tests: the Prostate Health Index, 4K score, something called STHLM3, MIPS, the Michigan Prostate Score. There's Confirm MDX. There's all kinds of genetic testing that we're going to talk about. There's MRI. In terms of diagnosis and staging, there's Polaris, there's Oncotype DX, Decipher, Artera AI against artificial intelligence testing. There's Germline genetic testing, and then all kinds of scans. And then in terms of survivorship and adjuvant or salvage therapy, there's, again, Decipher genetic testing. There's PET, there's PSMA PET, and there's Axman PET. What we're going to talk about mostly here is Polaris, Oncotype DX, now called the Genomic Prostate Score, Decipher, Artera AI. We'll talk about germline genetic testing. We'll talk about Decipher, and then in terms of survivorship, we'll talk about genetic testing also in terms of survivorship for patients who had treatment. So I wanted to start by talking about definitions. What is genetics? Genetics is the study of single or limited number of genes and their functions. It's often used to refer to testing for DNA mutations. It can be heritable, it can be tumor specific. What is the genome? The genome is all of the genes in an individual, and genomics is the study of the genome. Finally, epigenetics is the study of changes to DNA that don't involve changes in nucleotide sequence. And so, there's this line, my karma ran over your dogma. Well, this is the central dogma. So my karma right here ran over your central dogma. Some of you may, remember vaguely back into your early biology classes. This is like high school biology or college biology. DNA is this is the building blocks of kind of what we're made of. DNA is what's passed along from generation to generation. DNA is transcribed into RNA. So DNA becomes RNA, and only a portion of DNA becomes RNA. And RNA is then translated into proteins, and proteins are really what we're made of. And so it turns out only about 2% of our genome codes for protein. So some of our DNA really does absolutely nothing. In fact, as far as we know, it does absolutely nothing. In fact, the vast majority of our DNA, we think, as far as we can tell, does absolutely nothing that we can track, at least. And so it's really only the DNA that becomes RNA, that becomes proteins, that leads to changes in cells, and that leads to, turns into skin, and turns into prostate, and turns into kidneys, and all the other parts of our body. So this is like the central building block of what we're talking about when we're talking about genomics and genetics. So in terms of genomics, big picture, our DNA is made up of base pairs. There are 4 different kinds of bases. They pair up in specific ways. Bacteria have about 600,000 of these base pairs, and humans have over 3 billion. So other than red cells, all of our cells have sets of genes. We, as humans, have 23 chromosome pairs and 3.2 billion base pairs overall. And genes in general are the sequence, again, that make the proteins. And like I said, only 2% of the genome becomes the RNA that we think really matters. And just in terms of kind of the terminology, I want to talk about a gene like BRCA1 or BRCA2 that we worry about in terms of hereditary genetics. Everybody has these genes. It's just some of these genes can be mutated, and we call that like M-BRCA1 or M-mutated BRCA2. And it's to kind of understand this talk and this topic that we're going to be thinking about today, we really have to be able to tell the difference between germline mutations and somatic mutations, or germline DNA and somatic DNA. I'm going to try again with my camera now. My computer seems to be a little happier. So germline DNA is the DNA that's passed from generation to generation. It's the DNA that goes into sperm. It's the DNA that goes into ovaries. And when somebody has a germline mutation, those changes are in every cell of the body. And that's different than somatic DNA or somatic mutations. Somatic mutations are just in one cell or multiple cells in a specific part of the body. So a tumor can have mutations. If somebody has a germline mutation, tumor may have that mutation. But a tumor also, and typically does, have mutations that are just restricted to that tumor cell. And so this difference is really important. When we talk about hereditary genetics, we're only talking about things on the left. And when we're talking about tumor-specific changes, we can be talking about those changes in the DNA that are just seen in the tumor, somatic mutations. We can be talking about differences in RNA, and we can be talking about differences in protein, and that those may just be restricted to the tumor and not to the rest of the body. And so, again, this is just big picture background for this talk. There's inherited cancer risk testing on the left, and this is thinking about inherited mutations. We can identify those by blood testing. We can just do a saliva test because we're looking at DNA changes that may exist in every cell of the body. So it doesn't matter if we test tumor. In fact, it's more complicated if we test tumor. It's easier if we just test a random white blood cell that should be identical in terms of its germline genetic changes to the rest of the body. And we use that type of testing to assess for overall cancer risk, for example, and we'll talk a little bit about that. And so that's inherited cancer risk testing. Then there's this thing called genomic profiling. And here we're talking typically about these molecular signatures, and we'll talk specifically about these different signatures, usually talking about signatures like Decipher, Polaris, and Oncotype DX, which again is now known as the Genomic Prostate score. And so these are specifically looking at quantities of RNA of a given set of genes. And then there's this thing called somatic tumor testing, which can be also which is typically just done on the tissue, but can also be done by looking at circulating tumor DNA, which is often referred to as a liquid biopsy. We're not going to talk about this last, the kind of the third branch on the right. It's just a whole nother topic. It's usually restricted to patients with advanced disease. And so we'll kind of defer that for, we can come back and talk about that another time. So again, this is the crux of this talk is this table 1, risk stratification. It's in the NCCN guidelines. And there's clinical ways of doing risk stratification. There's artificial intelligence, there's gene expression testing, and there's germline genetic testing. And so, first of all, what are we talking about with risk stratification? That's the whole purpose of most of these tests is risk stratification. What we mean by that is, for a given patient, what are the odds that their cancer is aggressive or not aggressive? And can we personalize that for that question for that individual, right? We know, like, broadly, the NCCN risk stratification, which is a clinical risk tool, which is pretty blunt. It has risk groups like low risk, which you all, I'm sure, are very familiar with, based on things like Gleason score and stage and PSA. And it categorizes into, low risk, intermediate risk, high risk disease. Its main objective is risk stratification. How aggressive is somebody's cancer? There are more nuanced ways of doing risk stratification, and some of these are listed here. I'm going to highlight StarCap. StarCap is one of those systems developed. This one was developed at University of Michigan. Go blue again. And it's just another way to with a little more nuance to plug in all the clinical information, and then we get an output. And so if this is available on a website, again, this has been well published and well documented to be pretty accurate. Nothing is perfect, but pretty darn accurate. More accurate than NCCN risk grouping, to plug in a given patient's info and get things like a predicted risk of 5-year cancer-specific mortality. Here it's 0.1%, incredibly low. Note that that's with treatment if you read the fine print. So this patient would have a 0.1% of death from prostate cancer within 5 years. Of course, this patient is going to be recommended to go on surveillance with this very low, Gleason 6 cancer. It's really hard to get data on mortality for a patient like this on surveillance in most databases, although of course it's going to also be very, very, very low risk. And so the point here is to be able to use individualized patient information to give these risk estimates. That's clinical risk stratification. The good news is it's free. It also works really, really well. Now, can we do better? And that's really the purpose of gene expression testing with tests like Decipher, Polaris, and Oncotype. These tests use tissue from the tumor. They typically use tissue from the tumor that has been biopsied. And so one of the perks is that a patient does not need another biopsy to undergo one of these tests. Part of the technological revolution that enabled this is the ability to go back into the tissue that's from the biopsy that's been put in wax, basically. It's been fixed in formalin. It's called formalin fixed paraffin embedded tissue, put in formalin, like formaldehyde, and then put in paraffin or wax. And after the biopsy has been read, so some slices of that tissue were taken for the pathologist to look under the microscope. And after those slices have been taken, the rest of that block actually sits in typically a file drawer, very well organized, but it's a file drawer in the pathology lab and stored indefinitely. And that tissue that's been fixed and is embedded in wax can actually then be sampled further to look at the genes in that tumor. And in the case of these three tests, it's looking at the RNA expression of different sets of gene signatures. That means that if a patient has more RNA, it means more of that gene in that tumor. And that typically means that for each of those signatures, the higher score means that that patient has a higher level of risk. Now, what you'll notice that I haven't pointed out yet is these columns that say predictive or prognostic. And what I keep talking about here so far is association of risk overall for a given patient. That means for any patient, if you use one of these tests, do they have more, is the patient have more aggressive or less aggressive prostate cancer? That's a prognostic test. A predictive test, which you'll notice none of these are, would tell us for a given treatment, is a patient more likely to respond or less likely to respond. A great predictive marker would tell us that one patient is better suited for radiation and another patient better suited for surgery, or one patient is better suited for drug A and another patient better suited for drug B. We may have time to touch on that for germline genetics. In general, where that answer is a little more nuanced, but in general, there are very few predictive biomarkers, and most of the markers that we're talking about are prognostic. You'll also notice on the right that the level of evidence for each of these is variable, and the highest level of evidence are tests that have been subjected to randomized trials or been embedded in randomized trials. Most tests have not been. So there are these three gene expression classifier tests. Somebody mentioned earlier, we're not here to recommend one test or the other. That's a good thing because it'd be very hard to recommend one of these tests against the other. There's almost no head-to-head comparison. They all perform really well. They all have lots and lots of data to support that they work. And you'd have, even though they all use different gene sets, you'd have a really hard time telling them apart. And so, when I'm asked, and I deal a lot with these tests, when I'm asked, which test should I get? I'm going to get one. I have no idea, no way of recommending one test over the other. And it's not because of any bias or towards one or the other. It's trying to protect one, or it's just the data are the data, and the data are that all three of these tests do a really good job at risk stratification. Each one has a different threshold. So, we have that threshold here on the right. Each one is maybe initially designed for a different endpoint. So for example, one might be designed initially to predict mortality, another might be designed initially to predict possibility of metastasis, and another might be designed initially to predict change on surgical pathology from initial biopsy. But the reality is that they all work for all the different endpoints because they're all prognostic. And when we look at a test, I'll show a test here in a sec, or show a couple of the results. The reports that you get show these thresholds, but the thresholds are a little bit imaginary because the tests all report risk along a continuum. And so where you draw a line in the sand is actually in the eye of the beholder ultimately. So first, how should these tests be used? Well, any test in medicine in general should be used to help make a decision. So we might use a test to decide between active surveillance and treatment. That would be a really typical use of these tests. We might use a test to help us decide if androgen deprivation therapy is needed in addition to radiation, or if a patient might be able to undergo just radiation alone. Sometimes the tests are ordered just because we're curious. And I would say that's probably not a great reason to get a test, because it's just, if we don't have a way that we're going to interpret the test and use the test to inform some kind of decision, then it's probably not a useful test for us. So here's an example of a Decipher test report. Just real quick, what you'll see here is that the risk is graded from 0 to 1. This score falls somewhere between 0 to 1. These thresholds are given for context. We could argue that the thresholds are a little bit arbitrary. They're made with some thought for sure, but risk is a gradient, right? There's a 30% chance of rain or a 60% chance of rain. You know, if we look on Apple, I think at the 50% chance of rain, you're going to see the rain icon. But we know that it may rain at a 49% chance and it may rain at a 51% chance. And there's only a slight difference, of course, between the two. Whether we need to bring an umbrella would be, I guess, you know, an example. And then on the right, you can get these estimates of 5-year metastasis, risk of metastasis, 10-year risk of metastasis, and so on. And like I said, all of these tests are designed with all of these different endpoints in mind. This is the example of a Polaris report. I think the Polaris report is changing sometime in the coming weeks or months. But, you know, very broadly, again, what we get, if you look kind of on the number 6 here, there's this overall score from Polaris, and that's used along with the clinical information to then give this, if you look up in this number 4 box here, this predicted risk of disease-specific mortality if a patient is on active surveillance. Typically, that's going to be very, very low. And you know, there's a threshold here. Again, this is based on some data where this line is drawn, and yet still, it's at the end of the day, trying to draw thresholds here it has to be a little bit arbitrary. Is there a real difference between a 3% risk of disease-specific mortality and a 3.4% risk of disease mortality? Obviously, it's a very small difference. And then one thing that Polaris does, based on, again, some data, but still a lot more data needs to be generated to support this, is trying to draw the next leap, which is a recommendation towards surveillance, single modality treatment like surgery or radiation, or multimodality treatment like radiation plus androgen deprivation therapy based on that score. So that's how this data is presented, how it might be used. And I'll just, you know, this is ANCAN, so I want to mention the PROTECT data, right? This is the randomized trial of surgery versus radiation versus surveillance in low-risk prostate cancer. And this is the mortality figure, prostate cancer-specific mortality figure, where you've got 3 lines all superimposed. And so anytime this is actually older, the older publication, there's follow-up data. This goes out to 15, 17 years, that in patients with low-risk prostate cancer, we have a very hard time telling the difference in survival between a patient with, depending on how a patient is treated versus undergoing surveillance. Which is to say, if we're using this data to recommend a patient who would otherwise be a candidate for surveillance, that they be treated, we better have a lot of confidence that that information is really high quality and it's going to help a given patient. We can talk more about that maybe later in the questions and answers. I'll show a little bit of data from music that Howard mentioned. One of the things we look at in music is how often are these different classifiers ordered. And so each of these circles along the x-axis represents a different practice, so a different urology practice in the state of Michigan. The y-axis shows the frequency with which a practice is ordering genomic tests for patients with prostate cancer. And the size of the circle corresponds to the size of the practice, how many patients with prostate cancer are seen in that given practice. And what you'll see is that, then this is a few years old data, so it's changed, but it does give you some sense of, it actually matters what practice you go to, whether you're likely to get a genomic test or not. Some practices, as of a few years ago in the state, were ordering testing very infrequently. And there are some practices who order it kind of modestly. And there are some practices who order these tests on lots and lots of patients. And it's just an interesting side note, and that's another topic we could certainly delve into further in the questions and answers. In terms of how often do these tests impact decisions, we looked among patients with favorable risk prostate cancer, so low risk and favorable intermediate prostate cancer, and found that of patients above the threshold, so we would consider a high test, about 45% went on to surveillance. Of patients with a below threshold, a low risk test, about 76% went on surveillance. Now, of patients with no testing, about 58% went on surveillance. And you can interpret these data a couple different ways. One is, yeah, the tests are seeming to have an impact on decisions, right? There are more patients undergoing surveillance if they have a low risk test. You can also interpret this as the tests don't have as much of an impact as you might think. Because, for example, still 46% of patients with a test above the threshold are going on surveillance. And the flip side is still about 24% of patients with a test below threshold are not going on surveillance. So it's really important data that we need to think about. I'm going to skip over this one. I want to talk about G major for 1 second, since Howard gave us the shout out. And the purpose of G major is to help us actually in a prospective way understand what is the impact of these tests. And so it's a randomized controlled trial where patients with early stage prostate cancer, grade group 1 with more than 2 cores, so patients who don't have very low risk prostate cancer, or patients with grade group 2 prostate cancer are randomized to undergo testing with any of these 3 tests, or not undergoing testing. And so this is how we get high level data, and this is what's lacking in this space. And so when somebody says, boy, these tests are really standard of care already, I would push back, pretty strongly, because there has been no RCT in the newly diagnosed prostate cancer space to tell us how do these tests impact decisions. So in this case, we're measuring difference between use of surveillance versus primary treatment, and we're looking long term at what are the rates of grade reclassification, what are the rates of recurrence after treatment, what are the impacts on quality of life. And so this is a 900 patient trial. We've recruited about 300 patients to this trial, mostly in the state of Michigan, but just now expanded to the University of North Carolina and Fox Chase Cancer Center in Philadelphia. So this is going to be a really important trial, I think, for the field. We have so that was the G major trial. We've successfully run the G minor trial. We do like puns. This is the Genomics in Michigan Impacting Observational Radiation. And so this is for patients after surgery of high risk disease, stage T3, or T3 to T4, or positive surgical margins. PSA is undetectable after prostatectomy, and those patients were randomized to undergo Decipher testing, because Decipher is the test that's the primary test that's available in the setting of patients who have already been treated. And the question here is to look at the use of radiation after prostatectomy. And so these patients were randomized to Decipher testing or no Decipher testing. Again, we're looking at rates of radiation versus observation. Does the test impact clinical decisions, and does it impact outcomes? This trial is already fully accrued. We finished this trial a couple of years ago in terms of accrual. We've submitted the manuscript that, long story short, does show a difference in rates of adjuvant treatment in the arm, in the Decipher arm, for those patients who had high risk Decipher scores. And the real question is, does that lead to improvement in outcomes? Lower rates of recurrence, lower rates of metastasis, and that we do not know yet, but we will be able to report on that, we think, in the next couple of years. In terms of the ASCO guidelines that we published, this is kind of the take-home point. I hope it's really a take-home message from this talk, is that the panel endorses the use of these tests only when the assay results, when considered as a whole with routine clinical factors, are likely to affect a clinical decision. These assays are not recommended for routine use, as they have not been prospectively tested or shown to improve long-term outcomes. So select patients only when they're likely to affect a clinical decision. All right, I want to talk real quick about the Arter AI artificial intelligence platform. This just because it's in the guidelines. The way that this platform works is it uses clinical data plus digital pathology slides. So now, there are machine learning algorithms that can scan anything, right? This is how Google Photos works as well as does, and pretty much, every other AI feature that we interact with on our phones. In this case, it's taking the digital images from pathology slides and linking them, kind of every little possible detail, and many that we don't even understand, and linking them with clinical outcomes. And this machine learning algorithm can, look at different levels of muscle versus blood vessels. It can look at the structure of how the different Gleason patterns grow together. And it can look at standard things like Gleason grade and things that we, with our eyes, don't necessarily understand or recognize, and use that data to have its own proprietary algorithm based on just scanning a slide into a computer, and correlates it with outcomes. And already this is a product that's available. It hasn't seen widespread use yet. I think they're still in the process of commercializing it, but the data are quite good. And I'd expect that in the not too distant future, we'll be competing with these other tests. So the last part of this talk is germline genetics. HR here stands for homologous recombination repair. And so, right, we're talking about inherited cancer risk testing. So I want to make sure I leave plenty of time for questions. I think, everybody has heard of BRCA, I would assume. What does BRCA stand for? BRCA stands for breast cancer gene. Breast, right? You may not have known that. BRCA, we think about it for women. It turns out it's just as important for men. So it turns out, 1 out of every 500 women in the US has either a BRCA1 or BRCA2 gene mutation. But it's 50% of people with a parent who's a BRCA gene carrier. 1 in 500, every 500 women. Well, guess what? It's 1 in every 500 men too. Give me 1 second, just got another error on the screen, sorry. Try with my camera off again. All right, so how did this even become a thing that, right? I think for those of you who've been thinking about prostate cancer for a long time, you know that we haven't really been talking a lot about germline genetics and prostate cancer until maybe the past 10 years. And a lot of the credit for why we're thinking about it now goes to Colin Pritchard and the co-authors on this study that show that 12% of men with metastatic prostate cancer have germline mutations in their DNA damage repair genes, and BRCA2 is the most common of these mutations. Okay, and so this is men with advanced prostate cancer. It's not the case in early stage prostate cancer. And what you can draw from that is patients with at least some of these mutations are at higher risk of developing advanced prostate cancer. Again, BRCA2 is the most commonly seen of these in advanced prostate cancer. It's also the most commonly seen of these mutations in early prostate cancer. And this is particularly important because these are mutations that are inherited from one generation to the next, and they predispose to breast cancer, like I mentioned. They predispose to ovarian cancer, predispose to prostate cancer, it turns out, predisposed to pancreatic cancer, and some of these genes predispose to colon cancer. BRCA2 in particular is important because it predisposes to more aggressive prostate cancer, and possibly to some extent BRCA1, but really BRCA2 mutations are the biggest driver of worse outcomes for patients who have inherited a mutation in this gene. And so, for those of you who have seen graphs like this, you may it may make more sense, but this is something called a Kaplan-Meier plot. And the way we look at this is time on the x-axis, metastasis-free survival on the y-axis. So the higher the curve is, the better. Patients free of metastasis are higher. And here are the patients without. These are patients with prostate cancer. Those without a mutation in BRCA are in blue, and those with a mutation in BRCA1 or 2 are in the orange or red. And so it's showing that there's a real divide here in terms of the risk of progression, risk of metastasis, risk of death from prostate cancer for patients with and without mutations in BRCA1 and 2. Howard asked me to comment at least briefly on polygenic risk scores. And so if we just look at the big picture principles of hereditary genetics, we can think about on the x-axis here, population frequency, so how often types of mutations are seen. And on the y-axis, something called penetrance, which is how often those mutations lead to something that we can observe. And so for the most part, things that are really frequent, like a polygenic variant. And so what a polygenic variant is a very tiny change in somebody's DNA, it's often in the non-coding part of the DNA, and any individual one of these changes that's found has almost no effect. It's like the most minuscule of effect. But when you start gathering these different tiny changes together, we can create something called a polygenic risk score. And together, those actually can have a measurable effect. Still, that measurable effect is low, so it's on the low side, but it's more common. On the other side here, on the kind of infrequent side of the population frequency x-axis, you can see these rare pathogenic mutations, and that's what we call genes like BRCA1 and 2 when they're mutated. They're rare pathogenic mutations. They're individual genes. We know what gene they are, but when we find them, they do have a kind of modest intermediate impact. And so here, penetrance means development of prostate cancer. So these two different things, we got polygenic risk scores or polygenic risk variants, which can be combined to form a score that are common. And maybe you could define the threshold for how, like, what would be considered high risk, but you might say the top 10% of patients of the kind of the top 10% of the risk score is what we consider high risk. And that's where that lands in the population frequency, if that's where we define it. And then the impact on penetrance or development of prostate cancer is relatively low. Whereas these pathogenic mutations like BRCA1 and 2 are pretty darn rare, but they really have an impact in terms of risk of prostate cancer. This table just kind of summarizes what I mentioned. So we have these different genetic risk factors, these genes that we know about, the population affected. So really rare, 0.07% rate of BRCA2 mutations, for example. It shows the increased risk of prostate cancer. So in particular, BRCA2, also BRCA1, associated with worse prognosis. Yes, BRCA2 is associated with worse prognosis, BRCA1 probably. And then these genetic risk scores, and we can define a very high or high genetic risk score using, say, the top 5% of the risk score we might say is high. Then we say the risk of their prostate cancer for that population is 3.5 to 9. Whether those are associated with worse prognosis is still a little bit controversial, but for the most part, most data so far for most scores have shown that they are not, although some are being developed to try to deal with that, to really try to understand if we can use those to identify patients who have a worse prognosis. And again, this is a worse inherited prognosis, which is different than those tests that we were talking about earlier. What I think is really interesting is if you look at 3 different domains: family history, the rare pathogenic mutations like BRCA1 and 2, and the genomic risk scores, they are each important, and they're each independently important. And so that means that, like, somebody who, you take 2 people with the same family history and sorry, I got an error. I think I'm still going. The same family history and the same genetic risk score, and one with a BRCA1 mutation, the other without. The person with a BRCA1 mutation is at a higher risk of prostate cancer. And same goes if you hold 2 other things constant for any combination. So all 3 are important. They're all independently important from each other. What proportion of patients with localized prostate cancer have germline mutations predisposing them to prostate cancer? About 0.5% of BRCA1 patients, about 0.5%, or about 0.5% of patients will have BRCA1 mutations, about 1% will have BRCA2 mutations. Another gene called ATM is seen also about 0.5% of the time. In general, in particular for BRCA2, these are much more common in lethal than in non-lethal localized prostate cancer. So who should undergo germline testing? Amazingly, I think the best guidelines for this are the NCCN Genetic and Familial High Risk Assessment of Breast, Ovarian, and Pancreatic Cancer Guidelines. Believe it or not, prostate cancer is not mentioned in the title, and yet prostate cancer has multiple pages devoted to it, and it really, I think, sets the standard for genetic testing recommendations in prostate cancer. Now, the NCCN prostate cancer guidelines have really kind of adopted most of these, and so they've started to merge in the last year or two. But patients who we recommend genetic testing to are those with metastatic cancer, those who have certain form, like the way that the prostate cells form under the microscope when we look at it, are these features called intraductal tumors or cribiform, and patients with NCCN classic, like the NCCN criteria, high or very high risk prostate cancer. We can also use family history criteria and ancestry criteria. So we look at patients with who have prostate cancer themselves, and also family history of breast cancer, particular breast cancer at a young age, family history of ovarian cancer, pancreatic cancer, or metastatic or higher, very high risk prostate cancer. And also patients with Ashkenazi Jewish ancestry because of certain mutations in the BRCA gene. And then last, we talked earlier about some patients undergoing separate somatic tumor sequencing. And so when a mutation is identified in, say, BRCA2 on somatic tumor sequencing, it should also be looked at and confirmed on germline testing to see if that's purely a somatic mutation or if it's also a germline mutation. Just like summarize in like the most straightforward way that I can do it, basically for patients with localized prostate cancer, if they have low and intermediate risk disease, it's really kind of nuanced for who should undergo germline testing. It should, does require a conversation. Patients with a strong family history of those cancers that we talked about, maybe these histologies like intraductal and cribriform. For patients with high risk prostate cancer, it should be discussed regardless of family history, and same for patients with metastatic prostate cancer. How do we do it? Well, there are two ways. One is we see a patient and we refer them to cancer genetics. I'll tell you that the cancer genetics clinics in general are just overloaded. There aren't enough genetic counselors. It can take months for patients to get in. Many of you may have experienced that. And so we've really, among several other groups, have pushed for developing kind of streamlined approach in our own urologic oncology clinics. And so this requires us as urologic oncologists to have these initial discussions. We have to define the criteria for testing. I use the NCCN criteria, as well as there's a large group that got together, organized by Lenny Gamella and Veda Giri in Philadelphia a couple times, and developed the Philadelphia Consensus Germline Genetic Testing Guidelines. And they're all in the same ballpark, so we just need to have criteria for testing. We need to take a really good family history. We can't just ask about prostate cancer. We have to ask about these other cancers. We have to talk about really what testing involves with a patient, what the risks of testing are. It's not just like ordering a Decipher or Polaris test. These are tests that the patient has to understand may have an impact in terms of stress and potential testing for family members. There are some nuances about protections for federal protections that prevent discrimination from getting life insurance or health insurance, but those protections do have some limitations that we need to be knowledgeable about and review with patients when we recommend getting testing. We have to talk about insurance coverage and how much it might cost a patient. Many companies have a cap, they said. So if a patient is not covered for testing, that a patient won't get a charge of, say, more than a couple $100. We have to know how to order the test, and we have to, if a patient does have a positive test, we do have to know where to send them, because those patients need to talk with genetic counselors to talk about the implications of that positive test. Again, if a patient has a BRCA2 mutation, we're not just talking about prostate cancer, we're also talking about risk of breast cancer and risk, even for men, right? Male breast cancer. We're talking about potential risk for pancreatic cancer. And so we need to be knowledgeable about that. We need to be able to get them to cancer geneticists. Typically, these tests are a blood or saliva test. The panels include a number of DNA damage repair, homologous recombination repair genes. We have to, we counsel patients that they may have a positive test, they may have a negative test, and they may have something called a variant of uncertain significance. And that's a gray area. About 10% of patients will have a result that is probably negative, but we need more information, and often that information can take years for the field to develop to reclassify that variant of uncertain significance as either a positive or a negative. How many genes get tested? The panel is usually around 15 or 20 genes. There are some companies, I would say most companies will offer the option of 80 gene panel or 100 gene panel, but more isn't always better. The more information we get about genes that we don't really know about, the more confusing it gets. We don't know what we're going to do with that information, and the more likely we are to get a variant of uncertain significance result. All patients with a mutation identified that's pathogenic, it's called pathogenic or likely pathogenic, meaning it leads to prostate cancer, should see genetic counseling. And I still would say most patients who are in the gray area probably could benefit from a meeting with a genetic counselor. This is a study that we published. We had almost 300 patients come through our clinic, had the urologist perform the counseling, urologist or medical oncologist perform the counseling in clinic. and measured rates of satisfaction with the patient satisfaction with the counseling they received. And the vast majority of patients here in dark green or light green were very satisfied with the counseling they received from their oncologist or urologist. Again, genetic counselors are really key to this whole process, and you know, in my opinion, the linchpin of counseling of genetic testing. And so we work very closely with them. There are a number of barriers to performing genetic testing the right way. One of which is access to genetic counselors, urologists, medical oncologists. Patients all need education. We need, in general, more time with patients. There's some cost and insurance barriers, and just changing workflow in medicine is always a challenge. I'm going to skip that. So in terms of impact of genetic testing and localized prostate cancer for low-risk patients, there's some question of whether active surveillance is still appropriate for patients with, say, BRCA2 mutations. What I generally say is, you know, I go back to the PROTECT data, and boy, active surveillance is really safe for just about every patient. Prostate cancer, you know, a patient with prostate cancer with low-risk disease, it's, you know, a patient with a BRCA2 mutation certainly needs really careful counseling and may be appropriate for treatment, but I would consider that treatment more in the kind of the prophylactic domain, kind of like a woman who elects for a prophylactic mastectomy if they have a BRCA2 mutation. And the flip side is the patient with high-risk prostate cancer and mutations in one of these genes may really need multimodality treatment, and we certainly need clinical trials for these patients, because these patients are at a much higher risk of developing, say, metastasis from their prostate cancer in the long term, and we know that. And this is my last slide. Hopefully we'll have left enough time for some good questions here. And I just, you know, again, there are many different ways that we can measure risk for any given patient. We don't need all of these. We need to be selective about how we think through each of these. And I think it really helps when patients, you know, have an understanding of what these different tests are, and can help us think about what would be the best test for them. And with that, I just want to say thank you all. I'm sorry for kind of my camera and computer trouble, but I think we got it mostly sorted out. Appreciate it. Happy to take lots of questions.
Okay, well, thank you, Dr. Morgan. Really appreciate your time and explanation. We do have questions. I think Ben and Jim are going to pitch in. I have some icebreaker questions. One from the boss, and he says, can Dr. Morgan say a little more about his comparative study of the tests? You know, how is that going to work? And, you know, when are you going to publish? I mean, this is going to be an important test study, I think, in deciding which tests to use. And I don't know if you had to use shuttle diplomacy, but you got involvement, engagement by the three major manufacturers. But I know it's randomized, but it's not randomized where everybody gets all the tests, right? So is it still randomized? How's it going to work?
Yeah, so thanks. So the purpose of the study is to understand genomic testing writ large. So big picture for the field. Is genomic testing helpful for patients with early stage prostate cancer? It is not to tell us if Decipher is better than Polaris or Polaris better than Decipher or Oncotype / GPS. And in fact, the study is not going to be powered to tell us which one is better than the other. Nor do we think that that's a really super important question, because there's so much data that all three of these tests work really well. And so it's really, you know, when you do a randomized trial, what you're doing is you're comparing one arm with the other arm. And that means the testing arm with the non-testing arm. One of our concerns going into it is that some tests have thresholds, which we talked about are kind of arbitrary, that are lower than other tests. Therefore, on test A, you may be more likely to have a low risk score, and test B, you may be more likely to have a high risk score. And there's always been some concern that the ordering provider could cherry pick which test they recommend based on which result they want to get. If that makes sense. Meaning, if I think a patient will be better suited by having a low risk score, I might order test A. And if I think they would be more suited to a higher score, I might order test B. Now that's speculation, but we've guarded against that by mandating that every practice has that participates in the study has one test for the duration of the study. So I can't go back and forth between Decipher and Prolaris at U of M. We have a single test that is going to be the U of M's test on the study, and Fox Chase has a single test that's the Fox Chase test, and so on. It's a long way of saying we're not going to tell what test is better than the other. We're going to tell, does testing improve outcomes? Does it impact decision making, and does it improve outcomes?
So participants are going to be restricted to those 3 sites, or can other people participate?
There's about 10 sites that are participating. And so there's about 8 sites in Michigan, 7 or 8 sites in Michigan so far, and 2 sites outside of Michigan, and hopefully a 3rd site at University of Pennsylvania in the very near future. So a patient has to be seen at one of those sites that is participating and has to have been diagnosed within 9 months to be eligible. So it's not for patients that are on surveillance. It's for that have been on surveillance for a year or 2. It's for patients that are relatively recently diagnosed.
Is there a website or someplace people can go to find out more about it?
Yeah, I mean, it's on, so the music urology, Michigan Urologic Surgery Improvement Collaborative has some information on it. University of Michigan clinical trial site has some information on it, but the main study site would be the Michigan Urologic Surgery Improvement Collaborative has a link to it.
You know, I have a question that's sort of raised by one of the audience members who, well, I'm asking a question about him in a way, but I've heard this from other patients, and you know who you are. But some people have all 3 of these tests. Is that really necessary? Is that a waste of resources? Do people get something useful from each test, or?
No, absolutely not. Yeah, so this is just, it's totally understandable because the field is confusing and it's hard for us to communicate clearly, but there is no difference between one test and the other. The scores are pretty darn highly correlated from one test to the next. Now there are differences, but the scores are pretty well correlated. And if you get 2 tests and one's higher and the other's lower, you would have no idea what to do with the information.
So it's better, are you saying it's better to just have one test and stick with it?
And again, you should, the test should only be used if it's at an inflection point, at a point where we need to make a decision about something. And there's a real, tendency amongst everybody, patients, providers, you name it, to say, well, it's just another, let's just go, it's easy to just have the tissue sent off and get some more information. But what is that going to tell us, right? If somebody has been on surveillance for 3 years and they've had 3 biopsies that all show low volume Gleason 6 cancer, and then all of a sudden they get a Polaris test and it shows that they're high risk on that test, should that impact decisions? I don't know. What do you think?
I don't know. You're the boss on that one. I don't know.
Yeah, I would say no.
Well, let me put it this way. I mean, I've been on active surveillance 13 years. I've never had, one of those tests except for in a study. And I don't know which test I had. And I wasn't given a result, apparently because there wasn't anything to tell me. So, but for a pure person with a Gleason 6, who, it's kind of straightforward. Do they need to have one of these tests?
So off trial, the settings that I typically will order one of these tests is a patient who's in a gray area decision zone, and there are many, right? There are many patients who have higher volume Gleason 6 disease, lower volume Gleason 3+4, really any patient with kind of favorable intermediate prostate cancer who might be considering active surveillance. So when we're in that gray area zone, that's what the trial is designed to test, is mostly kind of more of the gray zone. clinical setting. But when we're in that gray zone where another data point may help us make a decision, that's when I get that test. You know, if a
Gotcha.
patient has favorable intermediate risk disease, and we have the initial conversation, and they say, you know, okay, I understand everything, and I'd like to go ahead with radiation or surgery. Again, that test doesn't help us with anything. But if they say, you know, I guess if I was like on the better end of the spectrum, I'd like surveillance. If you think I have more aggressive cancer and I should have treatment, then I'd do that. And we say, okay, let's let another piece of information may really help us. It's not these tests are great for that.
Yeah, Jim or Ben, do you want to step in?
Okay, Jim. So one question that I've had for a while is not so much a black box, but an empty box. My father had prostate cancer, and now so do I, and it's more than likely that I inherited it from him. But my germline testing showed nothing. This is not an uncommon thing, and I'm wondering why that happened. Why is there nothing in the germline test when I clearly inherited some cancer genes?
Yeah. This is so. If you go back to like thinking about that one slide I showed that spoke to 3 different factors: family history, rare pathogenic mutations, and polygenic risk scores. And all 3 are important, and all 3 capture something. And so you were tested for only rare pathogenic mutations. That's all that we have really available. And so check that one off the list. We still have two domains. One of them is these polygenic risk scores, and you know that could be a whole nother hour talking about that. But these are tests that are on the cusp of being commercialized. They're possibly even commercialized, like kind of at least on a experimental basis by some companies. Multiple companies will have them in the not too distant future. It's kind of like the 23andMe type of thing that's used for ancestry, but again, it's looking at cancer risk. You haven't, I'll bet anything you haven't had one of those tests yet, but it would be possibly available to you at some point. And so that could capture the answer. On the other hand, you could still be low polygenic risk, in which case we still have this third domain, which is this broad, just I have a family history. And that's important for reasons that we haven't yet totally identified. Could be other genetic factors we don't know about. It could also be environmental and / social.
Yeah, Jim, have you caught up?
Yeah. How widely are the polygenic risk scores being used? Are they moving out into routine clinical practice at this point? It seems like it would be a useful tool for a patient who's trying to decide on active surveillance or treatment or understand his hereditary risk.
Yeah, it's they're not used yet. They are on the cusp of being available, the cusp. Some companies have these. Now, what I would tell you though is they are designed for patients without prostate cancer who may consider how high risk they are for developing prostate cancer. For patients with prostate cancer on active surveillance who want to figure out, am I more likely to develop aggressive cancer in the future or not? There is only one study led by Bill Catalona that we participated in that has looked to help to try to develop a score of that nature. Still, you know, I would say early days for that. It's promising, but needs a lot more work and validation for something like that to be clinically available. But it could happen. I don't want to steal Howard's thunder, but it's a topic I know he's thinking about a lot.
Well, you're not stealing my thunder. Actually, I just had one of those tests. I'm supposed to get the results at the end of the month, but I look at it as more kind of experimental on my part. I'm not recommending them, but there are a number of companies that are getting into this, and there are problems with it. One of the bigger problems has to do with ancestry, racial ancestry, because as Todd Morgan has told me, I think that most of the genomic testing out there is based on European populations, and there's a lack of information about Asian, African American, indigenous peoples. They're missing that information. But it's out there. And Dr. Morgan, some patient's going to walk into your office and lay their polygenic risk score on you, and the rubber is going to hit the pavement, I think. But there is a lot of research going on about it. They've been looking at it for 20 years, and looks like it's being commercialized. I'm not going to plug any particular company or anything like that. But this is for common diseases like prostate cancer, breast cancer, cardiac disease, diabetes, Alzheimer's. So yeah, it's the genetic revolution may finally arrive yet in our lifetimes. But I have another question for you, Dr. Morgan. There's sort of a lore on the part of amongst patients that, and I've heard it from some doctors too, that Decipher kind of presents a more pessimistic prediction of what's going on. Can you comment on that?
Yeah, I mean, it's all, it goes back to threshold. And so my interpretation is that the high risk, or I should say so Decipher gives us two separate thresholds. I think if you recall back to the score sheet that I showed, there's the low risk zone and the intermediate and the high risk zone. And so a lot of it depends on whether you include the intermediate zone with the high risk, in which case that's a much lower bar, I would say, than other tests, and you're a lot more likely to have patients above that bar, which is set at 0.45 to 1, versus if you use the 0.6 bar, which is just the set that captures patients in that high risk zone and above. And so there are some settings where people have looked and considered anybody above 0.45 on that test as high risk, and in that case, it is undoubtedly more pessimistic. But if you restrict kind of how the threshold that you classify a high risk patient to that 0.6 bar, it's not so different. And so kind of a confusing and nuanced view. Ultimately, it's really hard to draw thresholds on any of these tests because risk is a continuum. And I'm not sure if I made that point too much, but I'll say it one more time, that a patient with, say, a 0.58 score on Decipher, this is a scale of 0 to 1, 0.58 isn't that different than a patient with a 0.62 score on the Decipher, and yet one will be high and the other will be intermediate. And so those cutoffs are a way that we have to kind of think in medicine, like somebody's above and somebody's below a certain threshold, but we really have to be sensitive to the fact that there aren't necessarily big differences for somebody just above or just below a line.
Thanks, Ben or Jim.
Do you foresee a time when a patient's genetic profile will inform more tailored treatment plans and more patient-specific treatments? And if so, where is it on the horizon? When's it going to be here?
And can I add something to that too, Todd? Maybe you can talk a little bit about pharmacogenetics and pharmacogenomics.
Sure. So first off, in terms of mutations impacting treatment, we're actually there. We're there for advanced prostate cancer. And this is the third setting. So I talked about hereditary genetics, I talked about somatic gene expression testing in the middle, and then I said I'm not going to talk about somatic sequencing. And it's that somatic sequencing in particular for patients with advanced cancer. When we find mutations in DNA damage repair genes in patients with advanced prostate cancer or advanced breast cancer, we may find mutations that are hereditary, but also still in one of them, like BRCA1 or BRCA2, and in a patient with advanced metastatic cancer. We know that certain medicines, certain chemotherapies, there's one called the PARP inhibitor in particular, that works better. And so that's always been the dream of personalized medicine, is we can identify a mutation or something about a given person in their tumor that says, this is the treatment, and it's going to work better than the average person. And so we're there for a very small slice of the pie. We need to expand that, so we have, not just the BRCA1 and BRCA2 telling us that a PARP inhibitor are going to work, but another gene that aligns with another therapy. But that has been the dream, and we're there for PARP inhibitors. We're there for some mutations that are associated with improved response to immunotherapy. We have a long way to go to expand that pool. There is a clinical trial that is open at a couple centers. We're opening it at U of M soon. It's called GUNS. It's being run by Marty Gleave out of University of British Columbia, which is for patients with high risk, untreated prostate cancer to undergo tumor sequencing. And then if the sequencing shows mutations in certain genes, that there are, say, four different pathways where patient A would get treatment A, patient B would get treatment B, and patient C would, and so on, before surgery. And so that's neoadjuvant treatment aligned according to tumor profiling. That's a clinical trial that we need to see if that works, but that's the key step before us seeing one of these treatments be used and personalized in patients with localized prostate cancer. So it's a very, very hot topic, and I would say imminently important. In terms of using our own individualized DNA information to guide treatments based on this, pharmacogenomics. So the idea is that you could do something akin to just like the polygenic risk scores, where we sample DNA and these small little changes and use that information and say, okay, person A should be dosed at some really high dose of a certain medication because they're going to metabolize it really fast, and person B should be dosed at a really low dose of that same medication because they're going to metabolize it really slowly. That's a really important field. I can by no means claim to be an expert in it, but I can say that we're certainly not at the point where that's being done clinically. But just like polygenic risk scores for prostate cancer detection, I think we're in the realm of that being reality.
Dr. Morgan, okay, so polygenic risk scores are on the short horizon or the long horizon, and somatic testing isn't for everybody. But should we all have our germline or inherited DNA tested, like through the PROMISE study? Well, not necessarily through the PROMISE study, but should all patients like us, get that information about our inherited risks? And what do you think about the PROMISE study?
Well, on a study, I would absolutely support everybody participating and undergoing testing. So the PROMISE study is a way for patients to undergo testing. It's organized through University of Washington, and the testing is done by, I think, Colored Genomics, and it just requires kind of online consent and sending in they send a kit and send in a saliva sample and undergo kind of standard excellent genetic testing. On trial for eligible patients, that contributes to science. It contributes to knowledge in the field, and it also could give you information about your own risk of aggressive prostate cancer in the future, or other cancers. So,
well, okay.
Study, I'm going to hedge. I'm going to give two answers here, because one is on study. Second is take that study out of the equation. Who should undergo genetic testing?
Yeah,
I really recommend it restricted to kind of that figure I showed for localized prostate cancer patients with high risk disease, or patients with patients with high risk disease, that's alone an indication. If somebody has lower intermediate risk disease, we're talking about patients with a strong family history of prostate, breast, ovarian, pancreatic, or colon cancer. We're talking about patients with Ashkenazi Jewish ancestry. and you know, or patients with intraductal cribriform histology, which is kind of a nuance that would be just in the pathology report, but not a blanket. Everybody with low risk prostate cancer should be tested.
You know,
What about somebody with high volume Gleason 6? Where do they fit in this?
They would still be considered low risk, and it would be based on the other criteria like family history.
All right, thank you.
And the rationale is just that the odds of having a mutation for a low risk patient with low risk prostate cancer is somewhere around 1%, 1 to 2%. So really, really, really low.
we have a really good question here having to do with the somatic or tests. I mean, those are one-time tests, right? If you have recurrent prostate cancer after a prostatectomy, you don't get another test, do you?
So for a patient who has, say, a Decipher at the time of biopsy, and then undergoes a prostatectomy, and then has a recurrence, I typically would not recommend another Decipher test because it's really unlikely that you're going to get more information from that second Decipher test, unless there was something massively discordant about the pathology from the initial biopsy that made you think that the initial biopsy didn't sample like the main tumor, right? So if the initial biopsy was a Gleason 3+4 and the final pathology was Gleason 9, and for some reason you thought that the genomic information post-op was going to help you with some decision, then you might want to retest. But that would be the exception to the rule, which is to say, yeah, it's very unlikely that another test is going to help you.
Now, Ben or Jim? Because I'll just dive in.
Go ahead.
Okay. All right. You said, you know, we don't really need to take each of the somatic tests. But if we did, you know, which one should we believe? You know, I mean, and how often do they disagree?
There's just, reality is there's not enough data, right? You would need to say how often they disagree. You would need to have the same tissue tested by each company. And there are a few very small publications on that topic, but they're way too small, in my opinion, to draw conclusions. And fundamentally, each of the tests work. You know, how do we, I didn't want to get too deep into the data on how we know each test works, but since we have, seems like we have a few minutes, the way that these tests were developed, every single one of them was using tissue banks. And so the reason these tests like Polaris and Decipher and Oncotype can all of a sudden be created now and couldn't have been created 20 years ago is there's this technology to go back to these pathology labs and pull out all these blocks of tissue from patients who have agreed, you know, had agreed to participate and have their tumors tested for these different classifiers and correlated with outcomes. And so each of these different companies performed RNA extraction, so getting RNA from tumors, and then looked at the quantity of RNA in each of these patient samples and looked across many, many thousands of patient samples, and then designed signatures that correlated with outcomes, meaning, say, odds of metastasis. And all of the companies went through basically the same process, more or less, slightly different technologies, but really the same process, all ended up with different signatures, different gene sets, but all developed very robust, validated tests that are associated with outcomes. And could one be, I mean, it could be a winner if you really did a head-to-head, but it would probably be a winner by a nose, and maybe one test happens to be better in some patients and one test happens to be better in other patients. You'd have a really tough time teasing that out. In my opinion, it's just not an important question, even though it seems like it should be a really, really important question. And I would liken it to almost, you get your PSA drawn. I mean, if Sunny's still on here, she's going to be maybe insulted. So don't repeat this to the Myriad folks, but because it's not, because the tests are all very sophisticated, but it's almost like getting your PSA tested at one lab and being really concerned that it's different than the PSA tested at another lab. They just are fundamentally similar tests, and they fundamentally give outcome data that are robust. And none of them are perfect, but they are all good. They're all high quality tests, and you would need a really big study designed to tell the difference between them to do that. And again, I just don't think that's an important study that needs to be done.
You know, you mentioned AI, the AI use with Artera, and you know how at this point it's being used, I think, to make decisions about androgen deprivation therapy, right? And the company has told me that they're working on testing for active surveillance as well. I don't know if you know much about that, but is there a correlation between genomic testing or somatic testing and AI findings, which are based on?
We don't know. We don't know yet. It hasn't been tested, right? You have to compare, same thing. You'd have to compare AI versus Decipher the same way you have to compare Prolaris versus Decipher or something. You know, ultimately the AI is developed in a very similar way, except instead of going back to all the pathology labs and getting all these old blocks of tissue, they're getting old slides that are scanned into the computer. That's their input, right? So in one test, the input is RNA. In another test, the input is digital information, a scanned in pathology slide that a pathologist would normally look at. But in this case, it's a scan, high quality digital scan. It goes into a computer, it goes into Artera's bank, and their machine learning algorithm gets to play the role of interpreting what information is relevant. Same, you know, yes, I'm sure they're going to do early stage disease so far. This has been embedded in a bunch of radiation oncology trials, so using data from patients who underwent radiation treatment, and using that is able to kind of make predictions, for example, like you said, about a patient who might have a response to hormones and need it, and a patient who might not. But it will be used to tackle all of the standard questions that we have in prostate cancer. And instead of the RNA being the input, it's the digital imaging. We, as humans, will not understand what information it is using, other than the algorithm is using the information on the slide in front of it.
Well, there was one sort of general question. One of the participants wants to wrap his head around what a mutation is. He's asking, are there degrees of mutation, and what's in a mutation?
Yeah, great question. So even kind of at the highest level, we talked about the central dogma, DNA going to RNA, going to proteins. And DNA is made up of base pairs, the alphabet. If you've ever seen the movie Gattaca, or movies like it, where think about engineering or changes based on the DNA itself. This is DNA is inherited, and then it goes into our different organs, and ultimately it's like the RNA and then the proteins that make our different organs. But it's at the DNA level that mutations happen, and a DNA mutation can be as simple as a single base. We codify it by 4 different letters, being like our alphabet. So T, T, A, G, C. It can be as simple as a T becoming a G, one thing flipping to another. It can be a run of those different bases being deleted. It can be a single base being deleted. But ultimately, when one of these changes happens, then the whole central dogma potentially can be thrown off base. And so if it's just the right change, then all of a sudden the protein that was supposed to have this really important function, it doesn't work. And the protein isn't made. And when that happens, so for BRCA2, that protein has a purpose, which is actually to repair other changes that happen in the DNA, amazingly. So it's kind of back on itself. So you get a mutation in a protein whose whole job is to guard against mutations, changes in the DNA. When that breaks down, you get more mutations and other genes that may go awry. And so that kind of becomes the cascade. And so at its core, it's and so that's, this is Gattaca. It's like you can engineer DNA to all this, so you can have a mutation that causes a problem, where you can also have a mutation that's like evolution theoretically, and this is the idea of actually gene therapy and trying to cure a disease like cystic fibrosis, which may be ultimately possible by changing a single part of the DNA.
Thank you.
Jim?
Frequently, when you get genetic test results, you'll see something that talks about a variation of unknown significance. Can you talk a little bit about what that is? And then, as I understand it, they follow up as time goes on, and they make determinations as to whether that particular situation is significant or not. Can you talk a little bit about that process, how it works, and what it means for a patient?
Sure. When we order testing, turns out that about 80% of the time the test is negative, about 10% of the time the test is positive, meaning a mutation is found that we think leads to a problem, like in the case of BRCA2 leading to the protein not working. And then about 10% of the time we find a change in the DNA that is different than the kind of the average, we call it the reference population DNA. So we all have actually, all our genes are mostly similar, but there are tiny little changes in all of our DNA, and not all of those changes, in fact, most of them are probably insignificant. And so the variant of uncertain significance is a change that's observed in an important gene, like say BRCA2. I keep going back to that because it's the most important one that we talk about and think about. And so there may be a mutation, meaning one of those base spaces is not the one that we expect to see in that gene. And yet, we're really not sure that that's a harmful mutation. And a lot of times, in fact, most of the time, it's not a harmful mutation. A variant of uncertain significance means that so far, with all the data that's available for that specific change, out of all the changes, that one specific change that that patient has, there's just not enough information to say definitively that it's negative, meaning it's not important, or that it's pathogenic, meaning that it's important, that it's causing the gene to be abnormal. And so then we end up with this gray zone classification. Again, it happens about 10% of the time. They do get reclassified over time as information builds over years, and say that let's say there are 25 patients found to have that exact same mutation. None of them develop aggressive prostate cancer. None of them develop breast cancer that's aggressive. None of them develop ovarian cancer. That starts to form the basis to reclassify that as not an important mutation. And so it becomes ultimately classified as negative. Only a couple % of the time is it reclassified as positive. And what that takes is same thing. Let's say there are 5 patients with that exact mutation and they're found to have aggressive prostate cancer or aggressive breast or ovarian cancer. And then all of a sudden it becomes clear that that's an important mutation.
Thank you.
Okay. Okay, there's people, no doubt, in this audience who not only have prostate cancer, but also have kidney cancer, I don't know, bladder cancer, breast cancer. So, I mean, there's genes involved with all of those. You know, are the prostate cancer genomic results affected by these other cancers present in the same patient? And we are trying to stump you. Don't.
Well, say the last part of the question. I want to make sure I got it right. So
yeah, well,
think about all these other questions. You're asking about is the same genetics?
Well, okay, I'll read it from somebody in the audience who said, how are prostate cancer genomic results affected by other cancers present within the same patient?
Got it. So the genomic, so a patient with multiple cancers, the genomic test. And when we say the genomic test, we're kind of colloquially, typically, thinking about Polaris, GPS, Decipher. Those are tumor specific. You only get information about the prostate cancer that's being tested. Absolutely no information about kidney cancer. Absolutely not impacted by kidney cancer or bladder cancer or anything else. It's just that tumor. The only setting where there's really an interrelationship is a patient with a germline change. So something in their germline DNA that's in all of their cells. And so a patient with what's called Lynch syndrome, for example, and so that's caused by a mutation in a specific type of gene that's, again, in charge of fixing some problems with DNA. It's something called mismatch repair, when the wrong base lines up with it's not the right match for it. And so there's a set of proteins, genes turn into proteins, that that is in charge of fixing that. Well, if that whole mechanism of fixing those problems in DNA is impaired, then people end up with a lot more mutations. And so these individuals are prone most commonly to colon cancer, but it turns out they're also prone to develop prostate cancer, and they're also prone to develop upper tract urothelial cancer, so a kind of cancer of the lining of the kidney, amongst other cancers. And so in that setting, those cancers are all intertwined by some of the same genetics, because it's the same fundamental machinery that's gone awry that's leading to these different cancers.
Gotcha. Ben?
So I'm asking this on behalf of Rick Davis, and I'll read his question verbatim. He said, a recent JAMA network article, Germline Genetic Testing After Cancer Diagnosis, suggested that between 2013 and 2019, only 1.1% of prostate cancer patients had done germline testing. What does Dr. Morgan think that number is in 2023? How do we improve the percentage? Who needs educating, the patient or the HCPs or somebody else? What would Dr. M do to correct the situation?
Well, first off, I have to admit, I have not seen that article, but I'm going to go look it up as soon as we get off. But I'd find that number to be wholeheartedly believable. Realistically, kind of advancing the knowledge around germline genetic testing in prostate cancer has been a thing for about 5 or 6 years, which falls kind of right in the middle towards the end of that window. And the question acknowledges this. Do I think the number has increased? Yeah, I don't know the number. I suspect it is, in advanced prostate cancer, I would expect that number at this point to be well over 30%. It should be probably 50 to 75% if we're doing the best job possible of educating. Some patients will choose not to have germline testing, very understandably, but the guidelines are to recommend testing with advanced prostate cancer. And localized prostate cancer is the subset of patients with high-risk disease or patients with a really strong family history that we talked about. And so ultimately, what should that number be? Thanks for that. I just saw that link, so thanks. I think that number in localized prostate cancer, if we're doing a really good job, it would be somewhere around 30%. How do we improve that? Well, I think everybody here knowing about it and talking about it is really important. For the last 5 years, we've given a course at the AUA meeting, so our annual American Urological Association meeting, a course for urologists that's really well attended about the importance of genetic testing and about a really specific how to do genetic testing. And so we try to educate as many urologists as possible. Medical oncologists are educating each other, radiation oncologists too, and patients educating each other and getting educated. All those things I think work together to make progress. Progress in medicine is too slow. The knowledge is there. We know we need to do it. It's in the guidelines. One of the stumbling blocks has been not enough genetic counselors, but as I mentioned kind of briefly towards the end, we're trying to overcome that by helping empower urologists, for example, to do the testing in their own, do the counseling and order testing in their own clinics.
Well, I think we're getting close to wrapping up here, and we appreciate your staying overtime. Jim, any final questions? Ben, anything?
No, thank you, Dr. Morgan.
No, no, thank you.
Yeah,
Thanks,
my pleasure. Thanks for having me. I really appreciate it.
Ellen, we appreciate it. And Rick, do you have any final words as we hit the road?
Well, I will be having some final words. As Rick would say, we have hit our witching hour. So I want to give a big thank you to Dr. Todd Morgan. That was a fantastic presentation. I want to give a big thank you also to Howard, Ben, and Jim for those great questions. And of course, everyone behind the scenes, Joe, me, Rich Jackson, and Rick as well. And we also want to thank you, Myriad. And we want to thank you all of our sponsors and Sunny. And we want to give just I love to thank people. If I did an Oscar speech, I'd be in big trouble. So I want to say that we will be having a survey after this that goes out when you exit this, and you will also get one via email. And please check out our groups. If you have any additional questions, feel free to bring them to any of our groups. We have a bunch of them, and you'll also be getting that in your email information too. So I bid you a great good night and a great tomorrow, and thank you, everybody.
Thank you. Thanks, Todd.
Thanks a ton.